Calf strains are a frequent challenge for athletes, especially those involved in sports demanding explosive movements like football, rugby, and tennis. These injuries typically affect the gastrocnemius, soleus, and sometimes the plantaris muscles, all crucial for running and jumping. The high recurrence rate of calf strains during competition highlights the need for effective management strategies. Despite their prevalence, there is no universally accepted guideline for diagnosing or grading these injuries, making return-to-sport decisions complex. In this video, we'll explore how imaging and injury grading can help predict recovery and guide athletes safely back to their sport. Imaging techniques like ultrasound and MRI play a pivotal role in diagnosing calf strains. These tools not only confirm the presence of injury, but also help localize the affected muscle and assess the extent of damage. For athletes, timely and accurate imaging can mean the difference between a swift return and a prolonged absence from competition. While clinical assessments remain essential, imaging provides additional insights, especially for complex or recurrent injury. Throughout this video, we'll see how integrating imaging with clinical evaluation leads to better outcomes. Mechanisms behind calf strains vary depending on the muscle involved. Gastrocnemius strains often result from sudden forceful movements like sprinting or jumping, leading to rapid muscle contraction and potential tears. Soleus strains are more common in runners, especially when running uphill, and usually develop gradually due to overuse. Plantaris muscle injuries, though rare, can occur with ballistic knee and ankle movement. Understanding these mechanisms helps tailor both diagnosis and rehabilitation, ensuring athletes receive the most appropriate care. Additionally, calf strains are graded based on clinical symptoms and imaging findings. Grade 1 injuries are mild, causing sharp pain but little loss of strength or motion. Grade 2 injuries are moderate, with temporary difficulty walking and noticeable weakness. Grade 3 injuries are severe, involving complete muscle disruption. However, modern approaches suggest that these categories may be too simplistic. Newer grading systems consider not just the extent of tissue damage, but also the functional role of the injured muscle, offering a more nuanced understanding of recovery. Ultrasound is a valuable, accessible tool for assessing calf injuries, especially in the acute phase. It allows clinicians to visualize muscle fibers, detect hematomas, and monitor healing over time. Most protocols involve scanning the patient in a prone position, starting from the knee and moving down to the Achilles tendon. Dynamic assessments where the ankle is moved during imaging can reveal important details about muscle function and injury severity. However, ultrasound is less sensitive for deep injuries, particularly in the soleus muscle. MRI is considered the gold standard for imaging calf strains, especially when injuries are deep or complex. It provides detailed images of muscle, tendon, and connective tissue, helping to identify the exact location and severity of the injury. MRI can also detect subtle changes like edema, fiber disruption, and aponeurotic involvement, all of which influence recovery time. For elite athletes, MRI is often used to confirm diagnoses and guide return-to-play decisions, especially when ultrasound findings are inconclusive. Recent research has led to more sophisticated grading systems for calf injuries. For example, the British Athletics Muscle Injury Classification (BAMIC) and the Olympic Park Classification consider not just the degree of tissue disruption, but also the specific structures involved, such as tendons or aponeuroses. These systems have shown better correlation with recovery times and help clinicians predict return-to-play more accurately. However, they require standardized imaging protocols and experienced radiologists for consistent application. Certain imaging findings are closely linked to recovery times. For instance, injuries involving aponeurotic disruption or large areas of edema generally require longer rehabilitation. Myofascial injuries, on the other hand, tend to heal faster. The presence of intermuscular hematomas, asynchronous muscle motion, or significant tendon involvement are all red flags for prolonged recovery. By identifying these features early, clinicians can set realistic expectations and tailor rehabilitation protocols. Return-to-play (RTP) after a calf strain varies widely, from as little as 2 weeks for mild injuries to over 12 weeks for severe cases. Studies show that higher-grade injuries, especially those involving tendons or aponeuroses, are associated with longer recovery times. For example, grade 1 injuries may allow return in about 17 days, while grade 3 injuries can take up to 48 days or more. The mechanism of injury, such as high-impact running, and the presence of re-injury also influence RTP timelines. The first days after a calf strain, management focuses on minimizing complications like bleeding and pain. The RIC protocol rest, ice, compression, and elevation is widely used. Nonsteroidal anti-inflammatory drugs are generally avoided in the first 72 hours due to bleeding risk. Instead, acetaminophen or selective COX-2 inhibitors are preferred. Early gentle movement and isometric exercises help maintain muscle activation without further injury. Imaging is often performed within the first week to guide further treatment. Rehabilitation after a calf strain is a stepwise process. Initially, light stretching and isometric exercises are introduced. As pain subsides, athletes progress to walking, eccentric strengthening, and eventually sport-specific drills. The timeline for each phase depends on injury severity and individual healing rates. Regular reassessment is crucial, as premature return can increase the risk of re-injury. For severe injuries, immobilization or surgical consultation may be necessary, especially if there's significant tendon involvement or persistent pain. Despite advances in imaging and grading, clinical assessment is still the gold standard for determining readiness to return to sport. Factors like pain on palpation, muscle strength, flexibility, and the ability to perform sport-specific movements without symptoms are critical. Imaging should be used to complement, not replace clinical judgment. This integrated approach helps ensure that athletes return safely and reduces the risk of recurrence. Current research on imaging and RTP in calf strains faces several challenges. Many studies have small sample sizes and focus on elite male athletes, limiting generalizability. Imaging protocols and definitions of RTP vary, making it hard to compare results across studies. Inter-observer variability in interpreting images can also affect grading consistency. These limitations highlight the need for more standardized research and protocols, especially for recreational athletes and female populations. Looking ahead, research should focus on developing validated, consensus-based grading systems for calf injuries, similar to those used for hamstring strains. Studies should also investigate how imaging can track muscle healing and predict re-injury risk, especially in the soleus muscle. Exploring new treatments like hematoma aspiration or the use of walking boots may further improve outcomes. Ultimately, a combination of clinical assessment, advanced imaging, and individualized rehabilitation will best support athletes in their recovery. Summary: calf strains are a common and challenging injury for athletes. Imaging modalities like ultrasound and MRI, combined with modern grading systems, provide valuable information for diagnosis and prognosis. However, clinical assessment remains the cornerstone of return-to-sport decisions. An integrated approach, blending imaging, grading, and hands-on evaluation, offers the best chance for safe and effective recovery. As research advances, we can expect more precise protocols and improved outcomes for athletes at all levels.